Okay, so my name's Darren. I'm one of the interventional radiologists downstairs. I did a talk very similar to this for the nurses in recovery, just to kind of give an overview of what actually goes on downstairs before the patients come here, and hopefully through the talk I'll address some of the questions that were asked about complications and why we do it through the wrist and those kind of things. So if you have any questions, just fire away, don't wait until the end. Okay. So I'm going to talk a little bit about why we do radial, because that was a huge shift in 2015 from what we did before. I'll talk a little bit about the safety around it, some of the concerns around radiation dose to the patient that were brought up. You'll notice that some of the patients who come up here have access either through their wrist or through their anatomical snuff box, and I'll go through why that is. And then just so you know what we do downstairs, why some patients who come up may have more pain than other patients, why they react differently, what meds they're on generally when they come up, and what they've had already and why we do it. And then just a few things around post-procedural management, when you should be worried, when things are pretty normal and not to be worried, and when you should probably give us a call and ask. So probably the biggest change in the last 5 years has been moving away from the groin going to the wrist. And so when we did this, it was based on a lot of data from cardiology. So cardiologists have been doing this for many, many years, and it was based around a lot of safety data with bleeding in cardiology patients, which isn't a huge issue with fibroids, because they're young female patients, they don't have a lot of atherosclerosis, and so the risk of bleeding in the groin is nowhere near as high as a cardiology patient who's had huge amounts of anticoagulation. But it's not zero. So, the question that we always get is, if there's no big bleeding benefit for fibro patients, why do we then do it through the wrist? And I'll show you some data that we have, but it's better for the patients. They can get up, they can ambulate if they need to immediately after the procedure. They're not limited to lying flat in bed for 4 or 6 hours. And so it does make it a lot more pleasant for them. For female patients specifically, not having their groin prepped, is a big deal for them as well. And so we asked patients many years ago, which one they preferred if they'd had both procedures done, and there was an overwhelming majority of patients who preferred having their procedure done through the wrist for lots of reasons. And the females that we asked, the most common issue with female patients and having their procedure done through the groin was the modesty issues and having their groin prepped by strangers, and it was a big deal for them. And so this in itself was enough evidence for us at least to carry on doing it. And I travel the world teaching doctors how to do radial intervention a lot for fibroids. This is a friend of mine who I taught many years ago to do radial intervention. She didn't do it for 3 or 4 years, and then she came to another talk I did when there was a conference here in Vancouver, and then she went back and changed her practice, and she hasn't looked back. And I think that's what happens with a lot of operators. First, when they think about doing it through the wrist, it seems like a long way to get to the pelvis, but actually in reality it's a lot easier and it's a lot faster. So we do it because we feel that patients prefer it. There's definitely less nursing intensity, there's no question, because you don't have to check the wrist anywhere near as often as you're checking the groin, and we'll talk about that later. Patients can walk around immediately after the procedure. They can be discharged technically the same day, which we do a lot at VGH. You often have to give less sedation because the groin can be uncomfortable to deal with. It's cheaper, there's no question, and there's way less vascular complications. So it was described actually by a Canadian cardiologist in the late 80s, and then this cardiologist described it first for coronary stent implantation. And that's kind of where it got its legs. This is a study that was done in British Columbia by a cardiologist many years ago. This was a registry where they looked to see why cardiology patients did so badly after coronary interventions. And so what they did was they looked at, you have to worry about the numbers, I'll tell you, but essentially what they did was they looked at the patients who had femoral intervention versus radial intervention and the number of transfusions given to each patient and whether or not that influenced mortality. And basically what it showed was that giving a patient a transfusion for an access site bleed increases their mortality a lot. So even if you don't see the numbers, if you look there, your 1-year mortality if you have a transfusion is about 24%. In a same cohort of patients, if you don't have a transfusion, it's 2.5%. And radial halved the number of transfusions that had to be given for these patients. So it's a massive difference. So we give transfusions all the time, but if you have a vascular access site bleed and you have to transfuse a patient, you're putting their life at risk. That's the bottom line, regardless of the procedure you're doing. So even in something like fibroid embolization, where we almost never have the complication, it's not zero. And that's why we transitioned to, one of the reasons we transitioned to radial. So in the cardiology space, the risk of bleeding is so high that for every 7 radial procedures that they do, they save 1 life. So their number needed to harm is really low for radial versus femoral. So it just shows you the impact that this has had on patient care. This is just another cardiology paper, but again, what it showed at the bottom really was the overwhelming patient preference for radial versus femoral. This was 7,000 patients that were randomized into radial versus femoral intervention. Where does it change our practice? So almost everything we do now is through the wrist, whether it's fibroid embolization, prostate embolization, trauma. We do a lot of trauma. So, trauma patients who come into VGH where they've got open book pelvic fractures, where they've got a pelvic binder on. You have to do a femoral intervention. You either have to take the binder off or cut through the binder to get to the groin. So there's sterility issues, and then there's an unstable pelvis, whereas you come from the wrist, that's not an issue anymore. So again, it's really changed the way that we deal with patients. We can stent from the wrist as well. We do a lot of celiac and SMA stenting through the wrist. So there's a lot that we can do now, especially because the equipment has gotten better and better over time. For many years, we were worried about, if we were doing radial intervention, if there was more dose to the operator and the patient. And so this was a cardiology paper that showed actually that it was less. And this is another paper, again, in cardiology, showing how the safety influenced the practice in the UK. This is our paper that we published a long time ago now. It's 2017, looking at our initial experience with like 750 patients, of which almost 90 were fibroid patients. And essentially what we showed is our complications are extremely low, patients prefer the procedure, and they ambulate almost immediately after the procedure for many. And then this is a study looking at liver intervention where patients were randomized into getting a femoral procedure, then the next liver intervention they got a radial procedure, and then the third one they could choose. And all of them chose radial. And the other thing that it showed was that the operator dose was much lower and the patient dose was lower. So all these issues around radiation protection and worrying about the dose to the patient, actually, it's not true. So the radiation dose is lower because you're standing further away from the patient, and also the dose to the patient is lower because your procedure is faster. And we also published on this a few years ago. So the thing that you probably noticed here in the last probably year and a half, maybe 2 years, is that some patients, not all, some patients come up to 1S with the hemostatic device in their snuff box rather than their wrist. So we, myself and a few of my colleagues changed a few years ago to working from the snuff box because it's a lot more comfortable for the patients, and as you've seen in the post-procedure orders, the time to get hemostasis is way faster. So these patients, when you puncture them through the snuff box, the hemostasis time is 10 minutes. Conventional radial is 25. So often these patients will not even leave radiology with the band inflated. It'll be completely deflated by the time they even go to peri-procedural care. And it's because, if you think about it, your snuff box, there's a bone underneath that you can feel the artery, it's easy to get to it, and it's easy to compress it. And it's also safer. The number of vessels that occlude or bleed in the snuff box is extremely low. The only thing is, because it's such a superficial vessel, even if there's a little bit of bleeding or even a little bit of local anesthetic that fills that snuff box, it will seem as if that patient has a hematoma. So I can almost guarantee that you are noticing more hematomas in the snuff box than conventional, but it's not a hematoma. It's often just local anesthetic or whatever that we fill the snuff box with. So just be aware of that. It's you can bleed into the snuff box, but it's probably what you're feeling is just residual fluid or a little bit of bleeding as the sheath came out. And the good thing with the snuff box access is it's not just radiology that's doing it. Cardiology is doing it. Interventional neuroradiology is doing a lot of it. So a lot of strokes, not really in BC, but in North America and in the US, are being treated through the snuff box as well, because it's such a safe access site. So, if you look at the data, there's all 3 specialties producing data at the same time. So why do we go through the snuff box? Lower risk of compromising blood supply to the hand. It's really low anyway with conventional radial, but it's even less in the snuff box. It's a very superficial vessel. It's very easy for us to puncture. It's very fast hemostasis, as you've seen. And if you do get an occlusion from conventional access, we can cross it. And this is essentially what we do downstairs. So we do an ultrasound essentially from the interosseous muscles between the thumb and the index finger, and then we kind of work our way down. So we kind of start somewhere there, and then we kind of work our way up to the wrist until we get to somewhere around there, where we're puncturing over the trapezium or the scaphoid. And that's normally with the site for us to punch. And then we're doing that because if you look on the ultrasound, I'll just kind of point this out to you. If you look there, directly under the artery is a bone. And so that's what's so easy to get hemostasis. And also, you can see here, this is the local anesthetic that we've injected, this black stuff here, that's local anesthetics. You can see how easily it looks like there's hematoma there. It's not, it's just local anesthetic. The other thing that you've probably noticed is over the last few years, the cocktail, what we inject into the patient's wrist has also changed. So before, when we first started doing radial intervention here in 2015, we were giving just 2,000 units of heparin. And we had a really bad complication at VGH a few years ago. It was completely unrelated to the heparin dose. It was just an unfortunate event, but it made me look at the literature, and most people have moved away from just giving boluses of heparin, and they now give weight-based heparin. So for fibroids, you'll notice, let me just go ahead one. So for 4 and 5 French, in general, we give normally 50 units or 75 units, depending on the procedure. But fibroids are 4 French almost always, and we still give 75 units of heparin. And you also notice most patients get 2.5 milligrams of verapamil, but fibroid patients get 5. So the reason that they get more heparin and more verapamil is because young females are the highest, or are the patients who develop radial spasm the most. And so those are all the patients that we see. So because they develop spasm more commonly, we give them more verapamil because it lasts longer. And we give them more heparin because if they do develop spasm, their risk of occluding their radial artery goes up. So you are dealing with patients who are in a very special group compared to anyone else that we treat, in the sense of they get more verapamil and they get a high dose of heparin. Because for a 4 French case, if we were doing it, that wasn't a young female, they would get 50 units per kilo of heparin and probably 2.5 milligrams of verapamil. And I'll talk about what that means later on, because it was something that the recovery team were really concerned about, because all the patients that were coming to them had very soft blood pressures. But it's a cluster of things. It's not just the verapamil that does that. So I'll talk about that a little bit later. And this is what the patients come up with. I think it's pretty rare for us. I think we haven't used the safeguard for a long time, at least for snuff box access, because we have this now, which is the sync distal. So the only difference between these two devices is that the balloon's a bit bigger on this, and this is a sticky one. But I think most of the time for snuff box access, you'll probably see almost always this one. What are they doing for conventional? Say we're using the safeguard. The sticky one.
Yeah, the sticky
for
one.
conventional.
Yeah.
So probably for conventional access, you're seeing the sticky one, and then for distal access, like I say, we're using this. And then all the patients get this little stat seal device, which is a hemostatic pad, which I'll talk about a little bit later, because there's a little bit of confusion, I think, sometimes as to what you tell the patient as to when that comes off. So I'll just go through what you should be doing. So again, hemostasis is much faster, and it's a conformable band. It means the patients can move their wrist. They're not limited in any way. And so you'll find that they have a lot more freedom after the procedure. So this is a study that we published last year. This is our rapid deflation protocol. This is that 10-minute hemostasis protocol. So we looked at it not just in fibroid patients. In fact, we didn't include fibroid patients in the study because we kept it all at BGH. But we did almost 600 procedures with up to 5,000 units of heparin, 10 minutes of hemostasis, and our complication rate was very low. And almost all the complications happened very early on in our experience with doing distal access. It wasn't related to the hemostasis protocol. So the big things that came out of this paper, number one, the nursing intensity was extremely low, because you only really have to worry about that wrist for 25 minutes after the procedure. Radial artery occlusion rates were 0. Small number of hematomas that happened very early on in our experience. So that's really been the biggest advancement, I think, in terms of what we do for these patients. And then these are just the cluster of cases. You can see we didn't include any fibroid patients in this study, but we used big sheaths, lots of heparin in it. It doesn't seem to be a problem. So just to touch quickly so that you understand what actually goes on and what we do downstairs. So we use an embolic downstairs called embospheres. It's a gelatin particle. They come in different sizes. They go from 100 microns all the way up to essentially 1.2 or 1200 microns essentially. So we use very specific sizes in fibroid embolization, and I'll talk about that in a second. And the size that we use is dependent on the plexus that supplies the fibroid. So we know the plexus supplying of fibroids has a certain vascular caliber, and those are the size particles that we inject. So all of the patients who have fibroids get the same size particles, except patients who have adenomyosis, which is a slightly different entity. It's where they have thickening of the endometrial stripes. It's a slightly different disease process that requires smaller particles, and I'll tell you why that's important. So the embolic we use downstairs has been studied for many, many years. It works really well. And what we're trying to do downstairs really is just to devascularize the cluster of blood vessels around the fibroid, and that causes the fibroid to infarct. So it doesn't infarct the uterus. So although we block off the arteries that supply the uterus, the myometrium is absolutely fine because the size of the particles that we're injecting are too big to infarct the myometrium. So the pain that these patients get is not because their uterus has infarcted, it's because the fibroid is infarcting. The myometrium is still getting blood supply. It's not that the myometrium itself is a problem. So that pain that the patients experience it's an ischemic pain related to the embolization of the fibroid. And that ischemic pain can be really bad, as you all know. It can be very unpredictable and very difficult to control. And again, we'll talk about that in a little bit. So we use embospheres. They are hydrophilic, and we moved away many years ago. When I started as a fellow here in 2010, we were using PVA, which is essentially plastic. There's lots of issues with PVA. I mean, it's a good product, but it's very inflammatory. It looks like this under a microscope, so I call it asteroidal PVA because it looks like asteroids. Whereas embosphere, they're well machined, they're round, and they also don't cause any inflammatory response, whereas PVA does. And what we're finding is patients tend to have a way worse pain after the procedure with PVA than they do with embosphere because they have a huge inflammatory reaction with PVA. So up until 2010, we were just using this asteroidal PVA, and then in 2011, we trialed loads of different embolics, lots of different ones, and we settled on embosphere because it worked so well. And so all our patients get the same embolic. We never kind of mix and match unless it's a huge fibroid. And we get into a point where we use so many syringes of embosphere that we need to just shut down the main artery, and then we'll inject a little bit of PVA at the end. So that's the only time, but it's very rare for us to do that. So this is just to give you an idea as to what we do when it comes to the procedure itself. So we use a single 4-French catheter. We often will use a microcatheter just so that we don't get uterine spasm. And then we use these two size particles. So we start with 500 to 700, and then we do 700 to 900. So we do 2 syringes of this, and then we normally do multiple syringes of this one because it's slightly bigger just until the artery blocks off. So when they come up, almost all the fibroids will have had those 2 size particles. And then just quickly, I hope this video plays. So this is what it looks like downstairs when we're doing it. So we come in through the wrist. You can see the wire kind of shooting down. This is the aorta. So it goes all the way down into one of the iliac arteries. It doesn't really matter which one. We can start on either side. And then we do lots of angiograms. So you can see this is an angiogram of the pelvis. This big squiggly vessel is the uterine artery. These squiggly vessels here are all blood vessels supplying the fibroid itself. So these fibroids can have a very, very rich blood supply because they're very vascular. And then this little squiggly thing that's in there is the microcatheter. This is the microcatheter here. This all is fibroid. All these abnormal blood vessels, these are all fibroid vessels. This here is the actual main uterine artery. And what we're doing is we're injecting the particles. You can see that red syringe on the end there. This red syringe is 500 to 700, and then I'm injecting them through a smaller syringe so I have much more control when I'm injecting. And then essentially what we do is we keep on injecting. You see now I've changed over to a green syringe. That's the bigger particle. And then at the end, when we inject, that's what we want to see. So you see no more fibroid enhancing. You want to see very slow flow in the uterine artery. You can see it's almost stagnant. But you're not seeing any of those big abnormal vessels anymore. Those are all gone. Those are blocked off. But there's still a blood supply going to the uterus. It's just very slow, and that's why they don't infarct their uterus. And so that's essentially what actually happens downstairs every time we do a fibroid embolization. And then at the end of the procedure, once you've sent the patients home, we bring them back at 3 months, and we do an MRI with contrast. And here, this is what the fibroids looked like before, and this is what they look like now. And so this is the myometrium, the muscle of the uterus that's enhancing with contrast, and these are all the fibroids that have infarcted, and that's the good response. So you will, in many patients, you will not see a significant shrinkage of the fibroids, but most of the patients, we don't do them because they have big fibroids, we do it because they bleed. So many of these patients won't have a huge decrease in size of the fibroids. We do this mainly for bleeding. Sometimes we can shrink the fibroids, but that's not really what we're doing it for. So if patients come to us and they don't have a lot of bleeding symptoms, but they have bulk symptoms, this is not the procedure for them. Then they should have a myomectomy or something. But the majority of patients who have fibroids have bleeding problems, and that's what bothers them the most. And if you ever read through the consult note what these patients come up with, if you look, you'll see that some of these patients bleed for 10, 12 days a month, change their pads 7, 8 times a day. They can't go to work for the first few days of their period. So it can be devastating from a quality of life perspective. So this procedure changes their life in that respect. So, and we do, as you know, we do a lot of them, and the main reason is for bleeding. So I'll just show you another case. So this is, again, a patient who's got lots of fibroids. You can see here. And actually, this little white thing here is the endometrial cavity. She's got a little fibroid in her endometrial cavity, and that will probably just slough off and she'll pass that. And you can have quite big fibroids in the endometrial cavity, and those will often slough off, and the patient will feel like they're giving birth because they're literally delivering a fibroid. So it can be quite distressing as well. And we warn patients, so if we see this on MRI, we warn the patient, you may deliver your fibroid. It can be painful at the time. But just so that they're aware, so that when they're at home and suddenly this happens, I don't think something bad's happened. And so again, there you can see all those very abnormal blood vessels, all these little squiggly things. These are all blood vessels supplying the fibroid, and this squiggly one is the uterine artery. The uterine artery, no matter who it is, that always looks exactly the same. And that's at the end. So you want to see all those abnormal squiggly lines gone. That's all the blood vessels supplying the fibroid. Same on the other side. This again, all those squiggly abnormal vessels are supplying the fibroid, and that's what it looks like at the end. And that's almost every case what we are looking for as well when we complete the procedure. So you don't have to completely block off the artery. You just want to kind of get rid of all those squiggly blood vessels, and that's what we call an embolic endpoint. Oh, sorry, I want to go back because that's an important slide. So I mentioned this adenomyosis thing. The only thing to remember with these patients is if they come up and they've had smaller particles, they've had 100 to 300, 3 to 5, 5 to 7, then 7 to 9, it means that they have adenomyosis. They don't have fibroids. Which also means that if you have if we've injected smaller particles, they're more likely to have way more pain. So if a patient comes up and they have more pain than you're expecting, if you just look through the notes and see, it's likely that they had smaller particles injected. And then for you, there's nothing more you can do. You can just top up their pain meds when you need to. But just so that you know why they're probably having more pain than the average patient, is often because we've injected smaller particles. And so the further the particles go into the uterus, the more painful it gets. So the more proximal you are, the less pain you cause. So the 1 to 3 and 3 to 5 particles do cause pain. So just so you're aware of that. What we do downstairs is at the end of the procedure, before we take the catheter out of each uterine artery, we inject 50 milligrams of lidocaine into the artery that supplies the fibroid. And that does help a lot with pain, but it doesn't last long. So unfortunately, and every patient reacts a little bit differently, it's likely that their PCA needs in recovery will be lower than they are when they get to you, because that lidocaine's often worn off. So unfortunately, it may be that the nursing staff in recovery don't deal a lot with patients' pain. So by the they come up to you and they have a low, their pain is well controlled, and then suddenly, out of nowhere, suddenly their pain's 9 out of 10. And the reason is probably because that intraarterial lidocaine's worn off. Just so you know. So you'll often be dealing with these patients where they've been fine for a few hours and then suddenly their pain shoots up. So again, don't get alarmed. Just encourage them to use their PCA, because they may not have been using it that often for an hour or two before they came up to you. So just make sure, and that's the thing with the PCA is just to remind the patients continually that they mustn't wait for their pain to get out of control before they hit that button. They've got to do it, as soon as they start to feel discomfort. And again, you can see how almost every fibroid looks the same. They've all got these very abnormal blood vessels, and the aim really is just to try and get rid of as many of these as we can. So just quickly, just to talk a little bit about some stuff, because there were some questions that I asked Brenda and Sandy to ask you as to things that we needed to address. One of them that came up was, what are the complications after the procedure? So I think the question of why do we do it through the wrist, I hope I've answered. The issues around complications after the procedure, there are almost no complications that happen immediately after the procedure. The reason for that is any complication that happens is a remote complication. So you will almost never see an acute complication in the first 24 hours. The pain is not a complication, that is just, it's a reaction to what we've done to the patient. So there are very few things you need to worry about when it comes to complications after the procedure. Pain is the biggest issue that you're going to have to deal with. And we've dealt with it a lot with the intraarterial lidocaine, but the problem is, like I say, it has a short half-life, and by the time they come up to you, that's probably worn off. So your biggest responsibility with these patients is really pain control. So they all get a PCA post, and the PCA's got clear instructions as to how much they're supposed to get, when the lockout is, and if you're really struggling, we write additional orders for Hydromorph. So if the PCA is not working, you can give Hydromorph for breakthrough. If you've given as much Hydromorph as the post-procedural orders allow you to, and they're still in a lot of pain, that's when you call. Okay? And again, it's not because something bad's happened. I can promise you it's not. It's just that the patient obviously is just more resistant to the pain meds, but it's good for us to know that. And then sometimes it'll just be reassurance. Sometimes the fellow or whoever will come out and see the patient, but that's when you want to trigger calling us, is when you've given as much as you can in terms of the PCA and Hydromorph, you still feel like that patient is not controlled, and then it's just worth giving us a call, so at least we can decide whether we need to do anything more. But again, encourage the patients to use the PCA and just reassure them, and then they go home, depending on who the attending is, either with Percocet or Hydromorph and Ketorolac or diclofenac. And the thing in the next morning, and all of you are very good, you try and get that PCA down in the morning. If the catheter is still in, catheter comes out, get them ambulating, get them to eat something, and then they start to feel a lot better, because that PCA, as you know, makes them feel terrible. Regarding the blood pressure issues, post-procedure, it is multifactorial. It's the patient population that you're dealing with, it's the procedure. The verapamil will have worn off by then, but I'll talk a little bit about verapamil in a second. So the problem is that these patients, when they come in, we don't do a baseline BP in clinic, mainly because for the last 2 years everything's been virtual. When they come into hospital, that baseline BP is not their baseline BP. They're stressed out, it's way higher than it probably normally is. And as you all know, young women generally tend to have low blood pressure. And so that systolic of 100 or a little bit less is probably their normal blood pressure a little bit lower, because they have mostly the opiates on board that drop their blood pressure. So it's almost always the opiates that do that. There's nothing we can do to get around it. But if the patient is asymptomatic, but they have a low blood pressure, but they don't feel bad, don't worry about it. You can bolus them with some fluids. They're young, they will absolutely tolerate it, but there's nothing more you have to do. So there's no need for hydralazine or alpha-1 agonists to try and prop their blood pressure up. It'll go, and often their baseline anyway is going to be low. So as long as they're asymptomatic, there's nothing you need to do. The verapamil is biphasic, so it has a peak at 4 minutes and then at 2 to 5 hours. So it may be immediately after the procedure when they come up to you that their blood pressure is low, because there's still some residual verapamil. And the other thing, verapamil doesn't just work on the smooth muscle in blood vessels, it also affects the contractility of the heart. So it's vasodilation and decreased contractility of the heart. That's what affects their blood pressure so profoundly. But again, it's a short half-life, and if their blood pressure is very low, the best thing to do is just bolus them with some saline or whatever. So again, it's a combination of the patient population that you are dealing with, potentially some verapamil left over, and the PCA. But if the patients are asymptomatic, they'll all recover within 5 hours of having the procedure. Again, young females are very sensitive because their baseline blood pressure is low anyway. Because we don't see this issue in our patients at VGH because we don't deal with this demographic there. We generally don't tend to do a lot of procedures on young, healthy females. So we just don't see the blood pressure as much as an issue there as we do here. And again, it's just because you are dealing with a very specific cohort of patients. So the reason that we do the verapamil and nitro, again, it's mainly for radial spasm, and because of that, to try and keep the radial artery occlusion rates low. That's why we give them the verapamil and the nitro. So again, if they're asymptomatic, they don't need any pharmacological intervention at all. Just give them fluids, keep an eye on them, and they often that blood pressure will kind of stabilize. But if they're asymptomatic, really, I don't think you need to do anything for them. So just in summary, I think we try our best to consult the patients about the pain after the procedure, but it's always good just to, reassure them that this is not unusual, that it's quite common, that you're used to dealing with it, so that it makes them feel a little bit at ease. Again, we do radial because it's easier to do from the top than it is from the groin. It's faster and they recover a lot faster. The pain we do the intraarterial lidocaine, but it's short acting, so they have to get a PCA anyway. And then, like I said, the hypertension post-embolization is multifactorial, but almost always doesn't require any pharmacological treatment. Just reassurance, keep an eye on the blood pressure, and like I say, bolus them with a bit of fluid. And then just one of the questions was about the neurovascular checks in the hand. So it's a very simple thing you have to do. Number one, whether you go through the snuff box or the wrist, there is no major nerve that goes anywhere near that artery. So the chance of having a neurological injury as opposed to the groin is very low. So the things you want to check for, and again, you don't have to do it many times after the procedure. The easiest way to do neurovascular checks is just to leave the pulse ox on the patient's thumb, because you're doing a vascular assessment continually, right? If the patient has a pulse, the vascularity is intact, because the thumb is the only finger, or the thumb and the index finger are the only two fingers in the hand that derive a sole blood supply from the radial artery. So if there's a problem with the radial, the pulse ox will be a problem. So there's your vascular assessment immediately, without you actually physically feeling for a pulse. There's your vascular assessment. From a neurological perspective, it's extremely rare, if not impossible, for them to develop a neurological complication in the hand. If they can't grip, it's often because it's a little bit uncomfortable and painful. So grip strength is not a good assessment of neurological status. You can just test their neurological sensitivity on the hand, but again, if it's a little bit dampened in the thumb and the index finger, it's because of the local anesthetic that's been injected. So again, you just get them to make a fist. If they can make a fist, they're neurologically intact, and you don't have to do that many times. Twice or three times when they come up to you. If they're already like an hour post-procedure, doing a neurological examination is almost pointless, because like that hemostasis is done. There's nothing really that you're going to gain by doing that. So almost always, and I'm not sure what my colleagues do, but almost always the neurological assessment that we recommend will have been done in peri-procedural care. So you shouldn't really have to do that. And like I said, you leave the pulse ox on their thumb, you've got a continuous assessment of their vascular status. And that's pretty much it. Alrighty, that's the talk from me. Any questions that anyone has, or things that are unclear, or that you want to just check on?
I have a question. It's not about so when they're not perfused anymore, and like you see them in 3 months, and it just looks, does it ever reconnect and start being perfused? Never. They just stay there.
No.
Forever.
So yeah, if you do an MR at 3, so it's a good question, because interestingly, if you have surgery for fibroids, you have a myomectomy, the fibroids can easily grow back even if you leave 1 or 2 cells behind. Whereas with embolization, because you're infarcting it completely, they never come back. If you embolize a patient very early on in her life, like sometimes we do very early 30-year-olds, if they really have large fibroids and they're very symptomatic, they can develop new fibroids. But generally over the age of 40, for females who have had fibroids, it's highly unusual for them, and they just sit there. And often, years and years after they've had their embolization procedure, if you do an MR, they'll have these infarcted fibroids that just shrink a little bit, and then they just stay there. They never really go away. Some patients it goes away, like we'll do an MR at 3 months and they're gone completely. Other patients like that, you do it, the uterus looks huge still. You speak to the patient and they are the happiest people you've ever met, because their bleeding is gone. So it all depends on what the indication is for the embolization as to what the expectations are. And so we try and manage that as best as possible in the consult clinic. So if a patient's main symptoms are bulk, we warn them and say, this may not sort your problem out, but if it doesn't, you've devascularized the fibroid, so if they end up having a myomectomy, it's a lot safer for the gynecologist anyway. Yeah, so it's a very common finding that on MR.
Yeah, interesting. And if they did get rid of them, then they would see that in the vaginal discharge, or would the body just absorb it?
No, they'll see it.
They'll see it always, yeah, okay.
And sometimes it looks like a really heavy period with like clots. It looks like clots, but it's fibroid.
Yeah.
Sometimes they'll literally deliver the fibroid as a whole fibroid. Other times it's bits and pieces. Like we've had patients who have delivered part of it and then they actually see the particles in the fibroid that we've injected, because the 7 to 900 you can see with the naked eye, you know. And some of the manufacturers color their particles. So each different particle size is a different color. So then they look at it, they see all these different color particles. It's really funky. So yeah. So it's not uncommon when they deliver the fibroid for it either to be in complete fibroid, depending on how big it was, or bits and pieces of it. But almost always it'll just feel like a very heavy period. They'll feel like they're just passing clots and stuff, but it's the fibroid. Yeah.
And that's a little bit later on, like they won't be passing it right after kind of thing. It's like quite a while later.
So all the issues that we see in these patients post is generally it'll start normally a week afterwards, and then it can go to 2-3 months post. So you'll never see any of the sequelae of that. Like they will never infarct and pass that fibroid in the first 24 hours. They'll be like, so that's the thing. So complications are virtually none. Like you'll never see a complication.
Right.
Yeah.
Any other questions?
Alrighty. Well, I think from myself and all of my colleagues, I just want to tell you guys, you do a fantastic job, and we really appreciate the help that you give the patients. It makes a huge difference. So thank you.
Thank you.
Thank you.
All right. And if you ever want to come down and watch a procedure, you're more than welcome. I'm sure Sandy can sort that out. If you're interested to come and watch one,